develop our skills in endoscopic sinus surgery. Of course, you would have seen many lectures on this sort of presentations, like, doing cadaver dissections, doing live cadaver, or you go and participate in a cadaver. You would have seen many of such things. But here, I'm going to give you a training during this corona period where you don't need a cadaver, but you can develop your dexterity. So this is going to be something which is, at least to me, the first time in the world that somebody is going to give a training like this. So that is why I thought, so what do we do during our corona period? That is when we are shut down at home. There's nothing to, so we are going on listening to lectures. But listening to lectures are not going to take you anywhere, because the person who is doing will always keep doing, and you will be, your hands will get sort of, rusted. So I always believe that you should do something to improve your skills during this period of complete shutdown. Maybe the shutdown is going to extend till, May, or maybe sometime more. But what happens to your surgical skill? The surgical skill slowly starts deteriorating. This is something which I want to warn every who has not really started swimming, or maybe not learned swimming as yet, that is doing surgeries as yet. So I'm going to, here in this Zoom lecture, going to definitely put into your mind how to do a dissection using endoscopic cameras, and this is what is going to be the main topic. Now, I thank Alembic. I thank Alembic for the opportunity given to me. I also thank my fellows, Dr. Sriharsha, of course, Dr. Chaitra is here with me, and also my sisters who have come during this shutdown period at the hospital to do this lecture demonstration. Well, yeah, I want to just tell you that if you have any questions, what you have to do is to put it onto the chat, and Sriharsha will put that question to me, and I'll answer the question. So this is going to be a series of lectures. Every lecture will be preceded by a little demonstration. So this is going to be different in that sense that it's just not going to be a lecture. It's going to be both demonstration as well as a lecture. But you might ask me, without a patient, how will you demonstrate? And that is what we're going to do today. Okay. Now, shall we start? Dr. Harsha?
Sir, just to announce, we have 500 participants to begin with.
Thank you. Thank you very much. It's all because of you. You've done a lot of homework, giving a lot of good publicity. And of course, there are so many people at home, so there's nothing much to do. And you will definitely get a very, very nice, steep learning in this particular lecture. I'm very sure about that. Well, let's get started. I'm going to be starting with, endoscopic sinus surgery. So endoscopic sinus surgery, I have been traveling, throughout the world, seeing a lot of endoscopic sinus surgeons, and I've seen a lot of top guys who have written great papers. But when you look at the skills, I find that the skills are not very up to the mark. Even though the papers are good, the books are good, but the skills are not up to the mark. But how do you develop your skills? To us in India, and also to those who really want to become surgeons and not to write just papers. So writing a paper doesn't involve skill. So you really want to become a surgeon who has got good dexterity, then I think you will have to do a lot of homework. So how do you do a lot of homework and get your hands trained? In endoscopic sinus surgery, it is not like any other surgery. This is the only difference between endoscopic sinus or skull-based surgery and a head and neck surgery or a ear surgery. What is the difference? In a ear surgery, you're looking through a binocular vision, and you have the depth perception, and you can operate with both the hands. It's a beautiful combination of both the hands. Whereas in endoscopic sinus surgery, the problem is you're seeing the monitor, which is away from the field of your surgery, and you're operating with your hand in a different place. So this is something which is totally different from the actual microscopic perception. This is why there is a very steep learning curve in endoscopic sinus surgery. This is what I am trying to tell you. And how do we improve our dexterity? How do we improve our dexterity? Of course, in microscopic surgery also you can do this, but I will tell you how to do it through an endoscope. So we're going to start this lecture with a demonstration now. My dear Harsha, you're going to change it to the endoscopic picture.
Yes, sir. Yes.
Yeah, you will be changing it to the endoscopic picture now, and I'm going to demonstrate how to. So I'm now going to start with my endoscope. Okay. Right. Are we ready? So you know how to hold an endoscope, right? You have to hold it like a flute. Of course, there are people who hold it like this. I don't believe in holding the camera. It's better to always hold the endoscope like a flute. So this is the way where the thumb is acting like the fulcrum here. You can see that thumb is acting like the fulcrum, and it's like a flute that you're holding the endoscope. So this is how you're going to hold it. And what we're going to do now is, can we switch on to the endoscopic view, please? Okay, right. You be there, you be there. It's just two-handed first. Yeah. Okay, right. Okay, now you can see here that I'm having something like this, a model like this. This is a very simple model you can make in your house. You can just make a small roll of paper. So you can make a roll of paper or a card, which is actually very, and then you can paste that. So this is what is called a JR sinus model. And what we are going to do now, what you have to do is sitting at home. I'm sure everybody has got an endoscope with you at home, and everybody has got a camera with you. And so what you have to do is make two holes. That is one hole either inferior or superior. And you can make that end of that hole which is totally empty. And with this, I will tell you some exercises which you can follow. This is called the JR sinus model. And you see how this model is made. It's like it's standing like this. Of course, like the patient, you can just introduce that endoscope slowly without touching the borders of the paper. So this is the first exercise I strongly recommend. Just 1, 2, 3, 4. Do like that. So at least 50 times every day, try to do this. This is very, very important. And you can see that there are some holes here, there are some letters here. Take a small ball probe. So all these you can definitely get in your home itself, and you try to introduce that slowly inside and try to draw this eye. That is, this is a 0-degree telescope. Try to draw this eye like this. Make this eye like this. You see here, and then you draw this N like this. So this is one way of improving your dexterity. In fact, when you're sitting at home, you can do this very easily. You don't need any cadaver. So in our center, what we do is we do at least 1 hour of this every day. We make the people do it 1 hour every day. And then what you can do, the third exercise, use a curved instrument like this, and without touching the walls, go and try to introduce this instrument. So this is something like the maxillary sinus. So this actually improves the dexterity completely. See here, without touching it, go inside, and so you can keep trying to do this. This is a very, very easy and very cheap exercise. So you can do that, but it improves the dexterity. So this is one way where during the lockdown period, you can actually try to increase or maintain your skills in endoscopic sinus surgery. And if you do this, believe me, in 1 month time, I'm sure that it will increase your skills and dexterity in endoscopic sinus surgery. Of course, I do not know how many of you have got this kind of model. You can use this model, and you see how I'm doing the surgery in this model. You can see it mimics the middle turbinate, the inferior turbinate there. I'm now trying, that's a superior turbinate. There's actually a model which is given by Karl Storz. So you can actually use this, and you can use the instruments also. You can use the instrument. I'm going to use my Blexley. Can you give me the Blexley? Now you see here, I'm trying to use my Blexley. There's a septal deviation here. You can see the spur there, acute spur there. Of course, you can definitely use this instrument and try to get your feel by slightly holding the middle turbinate, or maybe this model is slightly expensive. Of course, many people may not have this model at home, but I'm going to give you definitely a better version, a cheaper version for this. How are you going to maintain your skills without just listening to all the lectures? So now I'm going to show you how to do a four-handed technique. So four-handed technique on an egg. You see here, that's an egg model. This is a normal egg holder. So that's a normal egg holder. All of you have got it in your house. What you do is you wrap it around with an X-ray sheet. So this is an X-ray sheet. and I made a, go that side, and I've just made a small hole, like a keyhole here, okay? And now what you're going to do is you're going to have this egg. All of you will definitely get eggs at home. There is no doubt you will get an egg. And what you're going to do is to make somebody like your mother or your sister hold that endoscope. And what I'm going to do is I'm going to now start doing the 400 technique. Now you can see here that I'm going to start drilling this egg. You see here, this is very, very important. Now I'm just going to mimic a pituitary surgery, and you can see here. All of you can see it? Dr. Sri Harsha?
Yes, sir, we can appreciate, sir.
So that's a sella. Imagine that's a pituitary fossa, and I'm now trying to get that pituitary fossa out. So that's actually without any cost. You're doing this at home. You just have to have a mastoid drill. And of course, you don't even need a suction here, but try to gently go closer. Friend, be very careful. Ask your friend or anybody, or maybe your family member, to hold the endoscope like this, or you can hold it with your left hand. But it's better to ask somebody to hold the endoscope, because that's always better to improve your dexterity in skull-based surgery. Now, what you do now is, once you do that, you can see that membrane, right? Can you see that, Sri Harsha?
Yes, sir, we can see, sir.
Now, what you have to do is not to breach that membrane. It's very important that you should not breach that membrane. You see what I'm trying to do now? This is something which everybody can do at home, believe me. And what you can do is you can actually do that during this. Cut the. Water. Okay, now let us do this. Now you see here, what has happened now is I've made a cellar hole there. This I call as the egg training. Egg training is really, really good, my dear friends. I'm telling you to increase your dexterity during this period instead of going on listening to lectures. Believe me, this is another. So you just fix that egg. So I do this once a week at least, so that I don't miss out on my surgical skills. Now what I'm going to do now, box of okay, now what I'm going to do is, that's a plenum. So don't try to disrupt the membrane. That's very important. Don't try to disrupt the membrane. If you disrupt the membrane, believe me, then you're not a good endoscopic surgeon. So this is the carotid. Imagine that's the carotid. And now that's the carotid canal. Chaitra is giving me a beautiful view. Thank you, Chaitra. So all of you will be having endoscopes at home. See that? That's a small. If you don't irrigate, then you will have a little problem. You need an irrigation for sure. But that irrigation is disturbing you. So try to, now what happened is that I made two holes, and now I'm going to take my elevator. So elevator, Rosen's elevator. Okay, now you see here what I'm trying to do Now I'm going to try to remove this small piece of bone. This is what I call as the egg training. I need to do that a little bit. So see here, without any patient, without any any resource, you can do this. There are three ways in which you can do it. One is you can boil the egg. So to do a boiled egg is slightly easier than doing it in a fresh egg. Okay. No problem. Don't worry. Okay, I think that was free. That's why it came out. Now, having done that, now what I'm going to do is to try to slowly elevate that small bone. See what I'm trying to do now? I'll try to elevate without any shake of your hand. Try to do that in a very, very gentle. Go closer. The membrane is being attached. Slightly difficult in a fresh egg. See that now. What has happened now is that's the dura. Can you all see the dura now? Okay, now what I will do is I'll take a scissors. Now it's just going to be like the pituitary surgery. So I made a hole now. I'm going to take a straight scissors, which is here. And you can use a scissors, you can use anything in your house. And this is important. The dexterity with which you're going to do this is the most important thing. Hold this. Yeah, ready. Now I'm going to use my scissors now. Be careful, don't shake it. So that's the dural incision here. So imagine this will actually not cost you anything, but instead of wasting your time, this is something which you can definitely do at home. So you can easily do this because it doesn't cost you much. So you're trying to now incise the dura. There's actually the same consistency as the arachnoid, not the dura, but the arachnoid. I'm going to try to take that out now. I don't know how many people have done this before or how many have tried it. So if you have not tried, I have not seen anybody doing this in any conference. So I thought, I was thinking about it for the past around, since the shutdown, I did around 3 eggs. So this is what I wanted to show you as the egg training. So once you've done that dural incision, now what I'm going to do is I'm going to introduce the endoscope inside. You see here? So I'm going to introduce the endoscope inside now. You can see that's actually the membrane inside. You can see here that's the yellow and that's the white of the egg. And now I have to suck that without give me a elevator. So I'm going to make it very, very smooth. So you can do a lot of exercise now. So many from here you can go. I'm going to show you how to go from here because many surgeries are almost the same. This is actually the carotid canal. So this dramatically increases your dexterity. So you can have any sort of camera, vertec camera, anything. You just carry it in your any camera, any Chinese, whatever you want, you can take. So it's not that you should have a high-end camera. It's not. So that's actually the arachnoid. So I'm trying to take a flap of the arachnoid now, and that is actually the same like what you're doing for the pituitary surgery. I'm trying to. You can put a little. So take it off. So what you can do is actually you can suture this. With 9-0, you can try to suture it under the microscope. Of course, if you want to do that, you can do that. Now I'm just taking it off. Now I'm going inside, you see here. And now you can see that that's actually the membrane here. And I can make the incision now. That's actually the superior hypophyseal artery. And now I'm trying to make that incision. You see that how that is being made. So the dissection of the cranial pharyngioma. You can see that that's a small membrane, maybe a little additions. So why I'm telling this is because many people actually crib saying that, oh, I didn't get chances during my PG. You don't have to get, believe me, you can just do all this to improve your dexterity. And this just give me a suction now. Give me a very, so this imagine that this is going to be near the cranial nerve. This is going to be near the cranial nerve. And you see what I'm trying to do is, hey, hold the suction very slow. Yeah. See that now, I'm now trying to suck that white. So that's a CSF. That's a CSF now. I'm going towards the cavernous sinus. That is CSF. Have a very, very small suction in your house, and that's it. Don't try to disturb the mammillary bodies. The yellow is the mammillary bodies and the hypothalamus. So have the suction which is very low. Okay, now give me the scissors. Now you can see here that now I have created a arachnoid membrane over the suction please. Have both the hands, and then Chaitra is going to show me what I'm going to do inside now. This is going to be the real challenge. Now see how she's showing me and how I'm going to dissect this membrane. So that's it. So I opened it, you can see here. Now you can do a lot of things here. Now you can actually try to dissect this yolk here. Go inside. So you can actually try to dissect it out of its white, or you can make some. Or what you can do is, if you want to do an extra capsular dissection, give me. You can make it. You can actually boil the egg, and you can remove the white. And you see here, you can do an extra capsular dissection. It's going to be a firm pituitary. See here, I'm now going to dissect that yolk away. That's a tumor. So imagine how much you can actually think and innovate. So everything is in your hands. People say that, during shutdown, I don't have anything to do, just listening to lectures or the Zoom. Why? Why should you do that? Actually, you can do all these to improve your dexterity. When you go back to your surgical, now you see, I've left behind only the, maybe the mammillary bodies. And if you have it slightly, thicker, I can do an extra capsular dissection. So this is what I call the egg dissection. What you can do is now, come out. If you have this layer here, you can take a 9-0 and suture this completely. You can suture this completely. And once you suture this, you can try to invert it and see if the yolk is coming out. That means you have a watertight seal. So here you can learn the dural knot. You can learn the dural knot. This can be done with microscope or with, so I use three important things. One is I use the egg, and then I use the tomato. The tomato also can be used like this. So the tomato is you can peel the outside of the tomato and then use your dissection with the endoscope. And of course, the third is the potato. The potato, so the potato like tumor, come on, come inside, go inside. Chaitra, go inside. So now you see here that's the extracapsular dissection which you can actually create to dissect. So see that I can actually dissect it nicely, and you can get this tumor in toto completely. So that's the end of my first lecture. That was actually the first part of my lecture. Dr. Harsha, did you see that completely?
Yes, sir. Yes, sir.
Has anybody done this before, or this is the first time? I mean, at least the crowd which is sitting here. Let us have the participants' opinion now. Change the camera.
On it, sir.
So we have, one is the JR sinus model. Lights on, please. JR sinus model you have. The second is you have the egg yolk, the tomato, the potato. All these will actually increase the dexterity with which you are going to do your surgery when you come back with the surgery. So if the audience have any questions, I can answer it, or else we can go and start our lecture on. Of course, seeing a cadaver dissection is, not a big deal. Many people would have seen a lot of cadaver dissections. That's not the great thing. This class was mainly meant because I wanted to tell you during a shutdown, how can you increase your dexterity? This is one thing. And another important thing I want to tell you, get me the camera. I will show you something which is beautiful, okay? I'm going to show you this. This is the camera here. See here. Of course, you should have a camera in your house. That is definitely you will have a camera. So you can say, okay, you have a long pen like this, okay? And then, hold, my dear. So these are all things you can do. Believe me, these are the things which will improve your dexterity. By just seeing or listening to some X, Y, and Z will not increase your dexterity. This is going to be, hold it. Now, can you see? Of course, you not show the camera. Here, with this, what I will try to do is, I'll be trying to write letters. Holding the endoscope, I'll be trying to write letters here. And that is something which I can do to improve my dexterity. So these are all small things you can write with a pen, or both the hands can have some slow movements. Okay, Dr. Chadha, have you got any doubts or any comments at the end of my first part of the lecture? Come sit down here. Yeah, please go. Yeah, do you have any participant can actually raise their hand and you can ask some questions. So I think if you don't have resources, try to utilize the resources which you have at home. But only one thing I will tell you: to learn to swim, you have to go into the swimming pool. This is a very important fact. By seeing people swim or by seeing people doing surgery, you will never become a good surgeon. So this is the most important concept I wanted to convey to you at this moment of time, where we lack the facilities to operate. But still you can keep operating because you have all these under you. You can use a microscope or you can use an endoscope, whatever you want, but you can keep your hands still operating with just eggs or tomatoes or potatoes or cauliflowers or whatever. But basically keep using your hands. If you don't keep using your hands will get rusted. So how to hold an endoscope? Of course, you know that you hold it like a flute, and of course we're going to demonstrate all that. Now, Sri Harsha, are you there?
Yes, sir.
Is there any question from the audience? I'm not able to see. Or shall we go to the second part?
There's one question from Neeraj: how to hold the endoscope and how to insert the instrument so that they won't cross each other.
Yeah, that is very important. See, the basic thing is that, give me the endoscope. So you hold the endoscope, this is endoscope, hold the endoscope like this and make sure that your instrument is always away from the endoscope, that is below. I've seen during endoscopic surgery also, what happens is that you come like this, that is the instrument comes up, and if you do that, to me that's a wrong step. Never go above the endoscope, always stay below the endoscope and stay far away. If you're crossing or hitting, then you come out, see, and then go inside. So you have the leverage. In a patient, you can't do all this. But here you can see that. So that is what I want to tell you. Right. So any other questions? So I think there are something which are slightly good for the participants. Let us go on to the video. Let us start the cadaver dissection video. So how do I start? Screen share. Yeah. How do I screen share now?
Sir, there are a few questions that are coming up in
Yeah. You can ask me questions before the second session. So the first part of the session is over, because now we have actually stimulated all the participants' brain. I have told them there is no point in just listening or seeing people. I want you to keep your hands always mobile and always practicing surgery. And if you don't practice it for a month, believe me, when you go back, you're going to find it very difficult. Your hands will get different. So this is why I try to show this. So now I can take some questions and then we can start.
So the first question that reads is, what is the number of diamond burr used for the egg drill?
Oh, that's beautiful. Fantastic question. See, I'll tell you, if you're doing it microscopic, it's easier. Believe me, when you do it microscopic, the egg dissection becomes very easy. And actually, you start suturing with a 9-0. The burrs I strongly recommend are, you're drilling on the carotid. This is similar like the carotid canal. Believe me, this is the same consistency as the carotid canal. And behind it will be the dura, and that will be the membrane. So the best will be to use a 4-0 burr. So you have a coarse diamond burr and a fine diamond burr. The best is to use a 4-0 because that's the same thing you're going to use during surgery of the skull base, the surgery of the draft, surgery during the draft or draft 3 or whatever. 4-0 diamond burr will be the best. Don't use cutting burrs. Cutting burrs are dangerous. It will destroy the membrane. That is point number 1. Good question. Any other question?
What endoscope systems you recommend, sir, for the beginners?
Yeah, the best. See, I'll tell you, I have seen many people using a 70-degree in a step where it is not used. It should not be used or not needed to be used. See, Professor P.J. Ormond makes the frontal view it with a 0-degree. See, that is actually the correct brain. So don't try to show up by saying I'm using a 90-degree for the. Of course, in certain instances you have to use, but as far as possible, at least in skull base, you should not use angled telescopes. So use a 0-degree telescope throughout. But if you want to get trained with a 45 or a 70, you can use a 70 and do the same drilling. You can use a 70-degree, but it's a very difficult maneuver. To use a 70 and to do this drilling is really a difficult maneuver. Try that, but definitely during my next lecture, I will ask you how many of you did the egg model today or tomorrow. How many eggs did you do? How many of you could elevate the membrane? Yeah. Next question.
Sir, 4 mm would be fine or it would be large? That's the one question. And what is the size? 4 mm would be fine or it would be large? That is the first question. And
I'll answer your first question. See, 4 mm or 3 mm are the 2 burrs used in skull base. Okay, these are the 2 burrs used in skull base. At least what I have been using throughout my maybe 15 years or 16 years of my career are only 2 burrs. 3 mm burr and a 4 mm diamond burr. So this is the maximum you can use. Of course, if you want to do a mastoid surgery, you want to replicate it, of course you can use it. It could be the facial nerve canal. And you can drill with a 6 mm or 7 mm diamond burr. But don't use a coarse diamond because that will disrupt the membrane. You have to use a fine diamond burr. Okay? Any other question?
Dr. Manuel is asking, would you explain the optic 1, 2, 3, 4?
What?
Dr. Manuel Santos is asking if you could explain the optic 1, 2, 3, 4.
Optics, optic 1, 2, 3, 4.
What is optic 1, 2, 3, 4? I do not know what is optic 1, 2, 3, 4.
The position of the
Okay,
optic.
sir. We'll move to the next question. What doctor is asking, what you use as an anti-fogging? For anti-fogging, what do
you mean during the surgery or during the egg technique? So during egg technique, you can just use water. You don't need anything. But during the surgery, you use Savlon. But don't use Savlon if you're inside the brain. So we generally don't use Savlon. What we use is we have an anti-fog solution by Karl Storz. So we use that anti-fog solution. Don't use Savlon. Savlon is not available in some countries. I have gone to some countries, not found Savlon. I carried Savlon with me. The best, I think, is Savlon. Of course, you can use soap solution if you are doing the egg or maybe. But the best would be, some countries they use betadine also. I don't like betadine. The best would be water. Just water will be the best. So water is the best solution. I think Dr. Prakash Mukha sir has posted something. I'm not able to see that, but you can convey that question to me.
Dr. Mukha says that excellent example of egg practice. My compliments to your imagination, Dr. Janki.
Thank you, thank you. I was just thinking on the first day itself, because I was just thinking, if I'm just going to see others operate, how will my hands will go off? My hands will get rusted. So how do I improve my dexterity? This is what's going inside my mind again and again. So at least I've done now 2 or 3 eggs now, and I'm happy that I'm able to maintain my dexterity. So when I start operating maybe in May or something like that, I will not lose my dexterity. This is something which is very, very important. I am sure many surgeons, what they will do is once they start doing surgery, they, oh my God, I'm not able to even do a proper tonsillectomy. This is because your hands are not, you're totally now on the switch off mode. Don't do that. It's going to be very detrimental to your surgical skills. So that is why I thought, let me put forward this.
Can warm water be used as antibiotic?
Yeah, warm water at 40, you can use it, no problem. So use irrigation. The best I would suggest is this is the best time for you to learn four-handed. Ask your brother, sister, mother, or father, anybody to get involved. At least this is the time to ask them to get involved. Ask them to hold the endoscope or fix that endoscope with a holder if you have, and then you do four-handed surgery. This is the best for you to go into the skull base. Okay.
Was it raw or semi-boiled egg?
Best is used if you can do a raw egg. Just at least post that on my my Facebook or my WhatsApp. If you can suture, see, I will tell you. I will show you one of my videos where what I did was I removed that without a small hole, and I made the incision and I sutured the whole membrane with a 9-0, and you invert that egg and the contents should not spill out. If you have done that, I do it with the microscope. Of course, I can't do with that position with the endoscope. If you can do that with the endoscope, I think you will be the super best surgeon in the world. Believe me. If you can suture that with a 9-0, ethylone or something like that, proline or whatever, this will be the best exercise you can ever practice in this world. You don't need any, craniopharyngioma or a pituitary tumor in front of you every day. You don't need it. Okay? Right. I think we'll go on to the cadaver dissection. You stop me whenever there is questions. How do I screen share now? I'm going to screen share. Are you getting my screen now? No, I'll share first. Okay.
Sir, we can see your screen now.
Yeah.
So the turbinate view is visible now. Yeah.
Shall we start the video?
Endoscopic view is available. Yeah, we can start.
Okay, I'm going to start the video now, and we will start seeing the cadaver dissection. First of all, I want to tell you that in endoscopic sinus surgery, there are 3 different views you can give in the nose. One, put the light slightly down because I'm not able to see the video well. So there are 3 views. One is called the superior view, that is a view from above. And second is called the middle view, and this is actually a middle view. This is a middle view. This is called the middle view. When you see an endoscopic picture, you should be able to see, tell us what view you're giving, the superior view, the middle view, or the inferior view. Middle view means the endoscope is between the ala and the floor. So that is called the middle view. If you have a superior view, the middle turbinate will appear foreshortened. There will be a foreshortening of the middle turbinate. If you actually put it as the inferior view, that is when you place it towards the floor, there will be something like a paradoxical lengthening of the middle turbinate. So if you see the middle turbinate, like, maybe it is slightly inferior view, but definitely between a middle and an inferior view. During surgery, never give an inferior view. This is something which I want to tell all our participants, never give an inferior view during surgery. Now let us start with a video of the cadaver dissection. Why is it not coming, man? Chaitra? Why is it not coming? I'm trying to see, it's not coming.
Exit. Shows this and again close the video. Stop share.
No, why stop share?
Go to the
This one? Huh?
inside.
Can you see my screen, please?
Screen is visible, but endoscopic camera is still. We are unable to appreciate anatomy actually, sir.
No. There is a problem. It's got stuck.
Yeah, actually.
Stop screen share. Screen share has been stopped.
Okay. Now?
Select the video. Yeah. Put it in
PLC? Okay. Now I go for region of the adenoid and the landmark from rock. No, let the volume be there. Let us play the video.
You have to start the screen share, sir.
Go to the screen.
You have to start the screen share, sir.
Yeah. Screen share.
Screen share?
Share.
Yeah, it has come, sir.
Where is it?
Endoscopic camera view has come.
It is visible now.
That's it. You can put it this side. You can increase the size of this. Zoom on this.
Okay, can you see the endoscopic camera? I'm not sure.
Yeah, very much, sir. We can
Okay,
see.
start. We start with the diagnostic nasal endoscopy using a 0-degree telescope, and this is the aircraft technique. The landmarks being the inferior turbinate, the middle turbinate, and the superior turbinate. The sphenoid os can be seen in your picture. That's the axillary ostium which can be seen there. That's the floor. In the aircraft technique, the endoscope takes off in the anterior end of the inferior turbinate, flies between the middle and the inferior turbinate, and lands in the nasopharynx. Now we will see the landmarks in the nasopharynx. That's the eustachian tube orifice. That's the fossa of Rosenmuller and the region of the adenoids. Coming backwards, that's the axilla of the middle meatus, the uncinate process, the free border of the uncinate process, the bulla et modale, and that's the hiatus seminaris inferioris. That's the axillary ostium. That's the base of the triangle where we'll have to do an uncinectomy, infundibulotomy. The first step in the procedure is lateralization of the inferior turbinate with a Freer's elevator at the level of the anterior end of the middle turbinate. We never destabilize the middle turbinate at any given point during the procedure. We use a backbinding forceps and engage it at the antero-inferior quadrant of the bulla et modale, corresponding to the upper 2/3 and lower 1/3 of the uncinate process. The lower portion of the uncinate process is dissected submucosally. We can see the attachment of the uncinate process to the inferior turbinate. It's a U-shaped attachment. And then we debride the mucosa of the medial aspect of the uncinate process using a micro debrider.
we have devised an uncinate flap, and you're going to see how we do the uncinate flap. We take a sickle knife and submucously dissect the horizontal portion of the bone of the uncinate process. You can see very well the bone is being dissected away. Care is taken not to damage the mucosa on its lateral aspect. You can also see the natural ostium very clearly there. The mucosa on its lateral aspect is being gently teased out and the bone being elevated. This bone can go posteriorly till the palatine bone. We are dissecting that bone of the lower portion of the uncinate process. And once the bone is dissected out, we remove that bone with the Blakeslee forceps. The mucosa on its lateral aspect is preserved. That's a Blakeslee forceps used to remove the bone. Now we make a horizontal incision on the superior posterior border of the natural ostium, connecting it with the axillary ostium. We can do this with a sickle knife or a scissors, and we connect the natural ostium with the axillary ostium. The second step in uncinate flap is that we make a vertical incision along its anterior end. So we have a rectangular flap, and this is laid over the inferior turbinate. The reason why we do this flap is because the whole area is not made raw and it is draped with mucosa, and hence the incidence of ostial stenosis is very less. And that is why we do the uncinate flap. This is a 70-degree view of the maxillary sinus, and we can see the interior of the maxillary sinus, the intraorbital nerve, and the posterior wall of the maxillary sinus. Now we go for the upper border of the uncinate process. We use a ball probe and we tease the uncinate process, and we debride away using a micro debrider. It is not advisable to shear the upper border of the uncinate process because we need to see the superior attachment of the uncinate process, and that will give us an idea of the drainage pathway of the frontal sinus. We are now using a...
Now, I want to bring to your notice, how many of you, can you put on the light, are seeing this video? I hope all of you can see the video, Dr. Sri Harsha.
Yes, sir. There are 500 participants right now.
Okay, now you see, I was thinking a lot about this for the past many years. I have been asking this to various people also. I have still not got an answer. Okay, now I want one of the participants at least to, do this research. That is, many people talk about the Argonazi cell, right? The presence of an Argonazi cell. By definition, a cell should have walls all around and it should have a drainage pathway. Correct or wrong? Hello? Sri Harsha, you can unmute yourself and answer just the questions which I am asking you. Now, the Argonazi cell is a cell which is been traditionally called as the anterior most ethmoid cell. And we are, in fact, whenever we see the uncinate process, people say when you go up, this is the Argonazi cell, and according to Professor Frederick Kuhn, it is present in more than 98% of individuals. But honestly speaking, to me, is a classical Argonazi cell which has got an inferior wall with at least a drainage pathway for it. Even a concha bullosa, I find where it drains. But any of you have seen an Argonazi cell with a drainage for it? So now the question arises. See, this uncinate is going and getting attached to the lateral wall of the lateral nasal wall that's formed by the lamina papracia. Now, so most of the definitions say the medial wall of the Argonazi is formed by the lateral by the uncinate process. The medial wall of the Argonazi is formed by the uncinate process. So I am asking the people who have actually propagated about the Argonazi, what is the inferior? Where is the inferior wall of the Argonazi, which I have failed to see. Number two, where is the drainage pathway of this Argonazi cell? So to me, I think when you actually present this Argonazi, to me is actually a misnomer. In fact, we are writing a paper on this. I'm sure I'm going to publish this, but what I mean to say, such a simple thing, we have been talking about Argonazi. Let people come and show me ostium through which the Argonazi drains. Number two, let people show me where the inferior wall of the Argonazi is. And people talk about the recess terminalis. That is the terminal recess. That means this uncinate goes and gets attached to the lamina papracia. Once it gets attached to the lamina papracia, it is always forming a blind pouch, and that is called the terminal recess. I agree with that completely. But where is this Argonazi? So now in this class, I evoke a serious doubt to all the participants who are seeing here to tell me, does Argonazi really exist or not? So this is something which is there for your thought. But for ages we have been talking about Argonazi. To me, there is no real Argonazi. If you put your brain and think about it, to me there is no real Argonazi. So this is
70-degree telescope, and that's the Argonazi cell.
See, this is what I keep telling, and I have been teaching like this. Everybody has been teaching this. I do not know why we are teaching this. Believe me. Now you can put your comments. All of you can put your comments and say whether what I'm talking makes sense to you or not. So I request all of you who are doing FES, and please tell me how many of you have seen an ostium of the Argonazi. How many people have seen an inferior wall for the Argonazi? And just because you're seeing a terminal recess like this, don't say it is the Argonazi. Please comment.
Now we are going medially, posteriorly, using a frontal ball probe, and we push the Argonazi, that's the half egg, forwards and laterally, and now we are able to see.
So this is exactly what Professor Stamberger has been talking. Of course, I respect Professor Stamberger a lot. But my question to every rhinologist in the world is, where is this drainage pathway if this is going to be the Argonazi? And if it is going to be a half egg, why do you call it a cell? So what is this agar cell? So you can't call it an agar cell. So to me, I think it's a misnomer. Agar cell is a misnomer.
Inside the frontal sinus, we are now seeing the posterior table of the frontal sinus. The frontal butt is seen very well. The next step is to do a bullotomy. The bulla has got 6 walls. We puncture the bulla in its anterior wall.
Yeah.
There is an opinion from
the anterior.
Barkamol. In my opinion, when the vertical part of uncinate process joined to skull base and middle terminate, the agar cell will be completed.
No, we'll discuss about the Argonazi after this. The most important discussion will be about the Argonazi, the drainage pathway of the frontal sinus. We will do that. We will discuss that. So the uncinate process can get attached. Of course, I also agree with it. It can get attached to the lamina papracia, or it can get attached to the skull base or to the middle turbinate. I have seen all the 3 attachments, or sometimes even multiple attachments. Of course, I fully agree with all that. But I do not agree with the concept of Argonazi. So this is something which I want to tell this to the audience at this juncture?
An inferior quadrant is punctured. We use a microdebrider and we once open the bulla, we are now able to see the basal lamella. In fact, the retrobullar recess. We are now using it.
So when you do the bulla, I always believe that when you're doing maxillary sinusotomy, that's a middle meatal antrostomy, you do also the bulla if you have disease in the bulla or polyps in the bulla. You have to go right till the skull base. Many of them, they leave a little cell at the level of the superior end of the bulla. Never do that. So what we did was actually an intact bulla technique
removed
for the frontal sinus, the intact bulla technique, and that's actually the basal lamella. You can see that. Now I'm trying to remove that superior
preserve
cell.
the inferior wall of the bulla, and to do an anterior skull base dissection, we remove the suprabullar cell using a frontal ball probe. And once we remove the suprabullar cell, we are now able to see the anterior ethmoidal neurovascular bundle.
Now here I stop this video and show you that that's a frontal, okay? That's the anterior fovea. This is a part of the fovea, the anterior fovea, and that's the anterior ethmoidal artery. So you can, after the bullotomy, after the complete bullotomy, you are supposed to see the anterior ethmoidal artery. So this is something which I want to insist for every person who does a skull base dissection, that is the anterior skull base. You should see at the end of the bullotomy the anterior ethmoidal. There is only 2 to 3% of people who have an anterior ethmoidal artery behind the basal lamella. So this is also very important. Always seen in front of the basal lamella. Basal lamella is the coronal attachment of the middle turbinate, and the anterior ethmoidal artery lies in front of it. And the anterior ethmoidal artery lies behind the anterior superior attachment of the bulla. That's why we do an intact bulla technique for the frontal recess. For the frontal sinus, we do a intact bulla technique. So the anterior ethmoidal artery lies between the anterior superior attachment and the basal lamella. So whenever you do, you say that I've completed a bulla surgery, then you should be able to find the anterior ethmoidal artery. So this is very important.
That's the anterior.
If you have any doubts regarding this, you can put it forward. We will answer at the end of the session.
The neurovascular bundle.
So that's the anterior
The frontal
ethmoidal artery.
is seen very well. The anterior portion of the fovea, anterior ethmoidal neurovascular bundle is seen very well.
So this completes the bullotomy. You see, I've done a frontal, I've done an anterior foveal dissection. That's the anterior foveal dissection. I've done an anterior ethmoidal artery. A little bit of the posterior fovea is seen. So this completes a bullotomy, a frontal sinusotomy, and a middle meatal antrostomy. So if you want to complete your dissection of maxilla and also the frontal and the bulla, the anterior ethmoids, then this should be the end result of that dissection. So that is all. I mean, even during surgery, you should be able to see the frontal, the anterior fovea, the anterior ethmoidal artery, a small portion of the posterior fovea, and of course the maxillary sinus. So this is what I always believe. Then you go for the basal lamella. Here, very important that you retain a little bit of the floor of the bulla. This is very important. Many people take off the bulla completely. Try to retain a little bit of the floor of the bulla. This is very, very important.
Next step would be to puncture the basal lamella.
So when you puncture the basal lamella, puncture it at the inferior-medial aspect. So you puncture it at the inferior-medial aspect of the basal lamella.
The basal lamella is punctured inferiorly and medially, and then the Blakeslee forceps is used to bluntly dissect the posterior ethmoid cells. In this cadaver, we will be actually shearing the mucosa out, but in a live situation, we would like to preserve the mucosa. We take off the mucosa here to just demonstrate the anatomy.
Whenever you do the posterior ethmoid dissection, always look at the floor of the basal lamella. You just have to stay close to the floor. Don't direct your instrument and that is go posteriorly in
That's yet
superior
another cell
direction.
in the posterior ethmoids. We are now entering that cell.
So another important thing is that there are two things I want to tell you. Many people actually have a small doubt, especially the juniors. This is a cell or a skull base. So is this a cell or the skull base? So there are two ways of identifying, because the commonest site of leaving behind cells is the skull base. This is a study where they say that you leave behind a cell towards the skull base. So how do you make sure that you have completely, if it is a polyp or a lot of distorted anatomy, how do you make out that you have removed all the cell? I will tell you a very easy technique. The easy technique is, once you have done the frontal, if you have done an intact bulla, you have done the frontal, then just do the anterior fovea, anterior ethmoidal artery, and you will follow the posterior fovea backwards. So it tapers downward. So you know that, you see here, when you do this, it will not come like a step. It will be a smooth transition from the anterior to the posterior fovea. So if you find a step like this, that means it's a cell. But a better way to do it is actually to follow the skull base from posteriorly, from the planum, and then use a blunt curette and just curette the skull base. So this is a better way than doing an anterior posterior fest. So you see here what I'm trying to do.
The posterior ethmoid cells are more rectangular and larger than the anterior ethmoid cells. That is the posterior most ethmoid cell being entered.
So you can see that we are removing the
We can
mucosa
see
here.
that the skull base, the posterior skull base is tapering downwards. And now that's a 70-degree view.
Now you see here, I have used only 0-degree telescope all throughout, except for visualizing here in this cadaver. That's the anterior ethmoidal artery. This is the posterior fovea. This is the anterior fovea. This is the posterior fovea. The posterior fovea is here. This is the anterior fovea. The anterior ethmoidal artery runs from posterior to anterior obliquely. It runs obliquely. It doesn't run horizontally, it runs obliquely. It's very important. And medially, you will find that you can see the olfactory fibers. In many of the cases, you'll find the olfactory fibers coming from above downwards.
That's the anterior ethmoidal neurovascular bundle, the anterior fovea. That's the close-up view of the anterior ethmoidal artery. That's the posterior fovea. And the posterior ethmoidal artery is seen very clearly there.
This is the posterior ethmoidal artery, neurovascular bundle. You can see here the posterior ethmoidal neurovascular bundle. Okay, now see, you know that's the sphenoid, lateral wall of the sphenoid sinus. How will you differentiate a cell? You see here during surgery also, how will you differentiate? What the best way is, you can see the color, the change in color. The change in color will clearly be visible. The posterior fovea, that is the posterior part of the skull base, will be pearly white. And a cell will be bluish in color. You can see that very clearly.
That's the posterior ethmoidal artery.
You see the color, change in color.
Roughly corresponds to the anterior face of the sphenoid sinus. The next step would be to open up the sphenoid sinus.
So to open the sphenoid sinus, we have three different routes. You all know that's a medial route where you push the middle turbinate, push the superior turbinate and enter into the sphenoid os. Do not do that in fest because you're going to destabilize the middle turbinate. The method which Professor Stamberger has all taught us is to go through the posterior ethmoid here and go postero-infero-medial to it. And that I also don't recommend that because you're creating an accessory ostium. So the best is to create an intermediate approach to the sphenoid sinus. You see here?
And for that, we follow the intermediate approach. We create a superior meatal window. The landmark for creating a superior meatal window would be the inferior wall of the bulla leads us on to the superior meatal window.
So that's why I said retain this inferior wall of the bulla. This is like the tragal marker for the facial nerve. So if you draw a line from the inferior wall of the bulla medially, it will point towards the superior meatal window. So that is why I always say preserve the inferior wall of the bulla.
Once we debride the posterior aspect of the middle turbinate at its junction with the bulla, we have a glimpse of the superior turbinate. you can now have a very nice view of the superior turbinate, the end-on view of the superior turbinate there.
So you don't have to resect the superior turbinate at all. Many people think you have to resect the superior turbinate. It is not required. You can just retain the superior turbinate, and actually, of course, in this cadaveric dissection, I'm going to resect it, but you don't have to resect because there's a lot of controversy about loss of olfaction. See what I do now?
That's the superior turbinate seen very clearly.
And now
Here's elevator.
That's the intermediate approach. You see here, go between the middle turbinate and the superior turbinate and then visualize the sphenoid os. That is the intermediate approach.
Is used to gently push it laterally. The inferior third of the superior turbinate is punched out using a Karl Stover's true cutting forceps. So it is advisable not to take the whole of the superior turbinate, but just the inferior third of the superior turbinate.
Of course, you don't even have to take the superior turbinate at all. You can actually widen the ostium.
And once this is done,
this ridge of bone which separates the sphenoid os from its lateral wall is called the Parsons ridge. This is the Parsons ridge. You have to widen the sphenoid sinus at the cost of the Parsons ridge. This is very, very important.
Sphenoid os, the natural sphenoid ostium, is seen very well. And we use a Stamberger's mushroom punch to widen the sphenoid os. This instrument is a very useful and delicate instrument for the sphenoid sinus. It prevents injury to vital structures like the optic nerve or the internal carotid artery.
So how big to widen an ostium? We will discuss that when we finish this dissection. These are all going to be covered. The questions going to be covered. You just, yeah. So this is actually a type 2 kind of.
We use this punch to take away the bone till the skull base, and then a debrider is used on its lateral aspect till the orbital apex.
Never use the debrider inside the sphenoid. Never do that. Only on the anterior wall the debrider should be used. Never use it inside. If you use it inside, chance of damaging the carotid is very high.
Till the lamina papyracia. Now the sphenoid sinus is open very wide. You can see the optic nerve, the orbital apex. That's the optic nerve. That's the internal carotid artery. Very nicely seen in your picture. And that's the cellar floor.
Now imagine this. Okay, I did an anterior posterior dissection like this. Imagine that what you do is you do the sphenoid first, get the planum here, that's a planum, that's a roof of the sphenoid, and then use a blunt curette, that's a 90-degree curette you have, and try to gently curette it towards the lamina papyracia. That is, don't go towards the middle turbinate or the superior turbinate. Go towards the lamina papyracia and you come forward. Then if you find that the anterior ethmoidal artery is not decent, you can do it very easily and you will get the whole skull base. That is the simplest way to define the skull base. So this is what I want to insist again.
That's the posterior ethmoidal vessel.
So once you're experienced, you can do the anterior posterior approach, that is from the frontal, go back and then get the planum. But if you're a beginner, it is always better to go from the planum and then gently use a 90-degree curette and then gently curette all the cells out.
The skull base and the lamina papyracia. Once we go behind the middle malar antrostomy, in this cadaver, we had a posterior halar cell. That's a halar cell. That's a posterior halar cell. And once
that is a study which says that there are two areas, like the sinus tympani you leave behind the cholesteatoma. The same way in FES, there is a study that there are two areas where you can leave behind cells. So what is that? What are the two areas? The areas which are the commonest to leave behind cells. One is the frontal, of course. Some cells near the frontal can be left behind. The second is that is near the frontal and the skull base. And the second very important thing is behind the maxilla. Behind the maxilla, and the sphenoid sinus. If you draw a line there, some people leave behind a lot of, see, for example, this other cell could be actually missed. So the two important areas you should always remember to clear the cells, like in sinus tympanic cholesteatoma, the same thing is here applying in FES also. Clear the area between the posterior fontanel, that is between the maxillary sinus and the sphenoid sinus.
If you see a hallowed cell, we are supposed to connect it with the middle meatal antrostomy. Hallowed cells can be anterior, middle, or posteriorly placed. They reduce the size of the maxillary os. Now, we trim off all the bony spicules, and at the end of the procedure, we should have a smooth looking cavity without any bony spicules hanging down. That's the final result we'll have to achieve after a total sphenoid modectomy. That's a skull base, that's a posterior skull base, that's the anterior model.
So what is the most delicate part of this? Once you've finished it, of course, if your anatomy is distorted, where you will be very careful. This area is where you should be very, very careful. That is the anterior model artery entering into the skull base. That's the orbital part. This is the skull base part. You see how bluish it is. It looks like a cell here. The same in a live individual also, because the skull base is 0.05 millimeters in thickness. And this is where when you put your instrument medially and upward, so it's the entry of the model artery towards the skull base, it is easy to create a CSF leak. So that's the commonest site I've seen for the iatrogenic CSF leaks.
That's a remnant superior turbinate. The middle turbinate, very stable in your picture. The next
okay, so this is the end of the FES dissection, that is anterior posterior ethmoidectomy. Of course, we will take questions now. I'm going to stop share and I'm going to take questions now. Yeah. Now, are we ready? Because the cadaver dissection is over now. Yeah, here. Now, Dr. Sri Harsha, you're there?
Yes, sir. I'm here, sir.
Yeah, you can read the questions, or I can take the questions from the participants.
Yes, sir. Dr. Shagun Shrestha, preoperative and perioperative preparation for FES.
Okay. Yeah, that we are going to discuss tomorrow. Tomorrow we are going to talk about preoperative preparation for. So we have a series of lectures. Tomorrow is going to be pre-op preparation, and then intra-op in a polyposis, and then post-op. So that we are going to discuss tomorrow. Any other question?
Exercise and precautions to
How to suggest managing damage to the carotid during sphenoid?
How do you prevent?
The carotid during sphenoid.
How do you prevent an injury to the carotid? Okay, number one is that whenever you always identify the natural ostium or the sphenoid sinus. Point number one. Point number two is do not enter into the sphenoid blindly. Even a suction tip, if you enter blindly, it is a dangerous thing. Number three is never use a debrider inside the sphenoid sinus. Number four, or before all this, you have to read the CT scan, the coronal cuts of the CT scan, to see if usually the clinoidal part of the carotid is the more dehiscent part of the carotid. The other parts are not dehiscent. It's around 8 to 16% dehiscence of the carotid artery. The thing is, you should read it preoperatively and never use any instrument blindly inside the sphenoid sinus. This is the most important lesson which you should do when you do FES. You can use a debrider, but with control on the anterior wall of the sphenoid sinus. Never go blindly inside the sphenoid sinus. Okay?
One more question from Dr. Aditya. What are the exercises and precautions to be used while we just begin to start using a micro debrider?
Yeah, number one is, see, the micro debrider is actually a beautiful instrument. It's a beautiful instrument. To me, doing a FES without a debrider is like doing a mastoid without a drill. This is what I equate it to. So you should be conversant using the debrider, number one. Number two is, I have seen, even now I see some video, I saw some videos the other day, people are using a RAT 40 debrider blade for a bulla. I was actually laughing at that, because please do not use angled blades unnecessarily, because these are blades, because I always say when you use a straight instrument, of course, if you are very experienced, you can use whatever you want. But when you're posting that video for demonstration, people will observe you. So this is very important. Use always straight instruments, because the pressure which you have here will be the same pressure here. But the angled instrument, you don't know what pressure the tip of the instrument is going to generate. The tactile feedback to the brain is different when you use angled debrider blades. Use straight debrider blades, number two. Number three is that when you use a debrider, please understand that the faster the debrider rotates, the lesser will be the tissue it will be sucking out. If you are rotating the debrider slower, the more tissue will be sucked. This is very important. It's actually the opposite to a drill. So this is very important. Number four is that do not face the debrider blade towards vital areas. For example, if you are using it on the lamina papyracea, you have to use the guard towards the lamina papyracea. So if you're using it on the skull base, be very careful when you're using the guard towards the skull base. Use the guard towards the skull base. So if you're experienced, you can do whatever you want, but it is always better in your initial period when you're learning with the debrider, don't use the cutting edge of the debrider towards vital areas. This is what I want to tell you. Yeah. Anything else?
What is the limit of the sphenoid?
What is what?
Inferior limit of widening of the sphenoid sinus.
Oh, that's a very good question. See, I'll tell you, previously when I used to demonstrate, or even when many people used to demonstrate, they have written textbooks also, they always say widen the sphenoid inferiorly. That is the safest. Nowadays, we don't do that. We now know, after the advent of skull base, that there is an artery, which is the posterior septal branch or the sphenopalatine artery, which is running inferiorly. If you want to widen the sphenoid inferiorly, what you have to do is to make a gentle incision there, elevate the mucosa, then you widen it with a mushroom punch. Do not damage the mucosa inferiorly. So inferior widening, I do not agree. The best widening is lateral, anterolateral widening, not superior. Superior you will have around 5 millimeters. But anterolateral widening at the cost of the Parsons ridge. But in sinusitis, that can be really thick. That bone can be really thick. You have to widen it by gently opening that blechously. Introduce the blechously into the ostium and open that blechously. Reverse. That's not the plucking way, the reverse way. Then you will break the Parsons ridge, and then you can use a sphenoid punch and widen it at the cost of the anterolateral wall. Don't widen it at the inferior wall, because it will produce a lot of bleeding. Okay, and if you need a Haddad flap, then it's going to be difficult. Yeah.
Sir, there are few questions regarding frontal sinus.
Yes.
Sir.
Yeah.
Is how to dissect the frontal with 70-degree endoscope.
Yeah.
One is that question, and the other question is how to differentiate the agar cell opening and frontal recess for sure.
Yeah.
And tips to enter frontal sinus safely. And yes.
Yeah, I will now show you the video. Hey, where is the video now? Can you show me the video? See, I asked one question about how many people agree that there is a Argonazi cell. So this is, I asked you, but I think nobody has commented about that. Okay, let us now see this frontal sinus dissection. Can you see the screen sharing now?
Not yet.
Dr. Krishna?
Not yet, sir.
Not yet.
Not yet, sir.
Okay, share. Now can you see it?
Yeah. Endoscopic view has come.
Okay, now what I'm going to do is to show you how to easily access the frontal. Okay, easy access to the frontal. So now I've done the maxilla. That's a 70-degree view. The first step in frontal sinus dissection should be, first you elevate this uncinate process with a ball probe. Gently elevate it with a ball probe like this. You just medialize that ball uncinate process. Now after that, you try to debride this part of the uncinate process. Some people use a 90-degree Blakeslee forceps. You can use it. What you have to do is to gently debride this and then come to its upper limit. Okay. Once you come to its upper limit, if you are doing so from here you can take an intact bulla technique, or you can do a bulla down technique. So if you are doing an intact bulla, why do you want to do an intact bulla? Because you are going to prevent injury to the anterior ethmoidal artery. So that's why you are doing an intact bulla technique. So now you use a 70-degree telescope, or you can do an axillary flap. If you're not very conversant in using a 70-degree, best thing is to take an axillary flap. That is, take a flap here and then punch off this bone. Then you can use a 30-degree or a 45-degree. But without doing an axillary flap, doing it with a 30 and a 45 is a little difficult. So if you are not conversant in using a 70-degree, try to do an axillary flap technique as described by Professor P.J. Ormold. So that is the best way. Now the question is whether there is Argonazi or not. That itself is a big controversy. I do not agree that there is an Argonazi. But whatever you see above, just follow this uncinate process. See this uncinate. You are left behind. What is this? Somebody has put a...
Someone else has done, not from our side.
Okay.
Yeah, we would request participants not to use annotation model.
But will that appear on all the screens? I don't know why it's appearing on the screens. Now, please don't put that yellow mark and things like that. Please. Don't use annotations. Now you can see the upper part of the uncinate process. You see here, always in live, see the upper part of the uncinate process. This is very important. You can then decide, of course, in preoperatively you will see it. Preoperatively, then intraoperatively you see it. If it is going towards the uncinate, middle turbinate, this is the simplest frontal you will have. Tomorrow we are going to show you so many videos on the frontal sinus dissection. But if the uncinate is towards the middle turbinate, it is the lateral drainage, and it is very simple to open the frontal. It will already be open. So that is second. Then third, if it is going to be towards the lamina papyracia, forming the recess terminalis, gently push your ball probe. Use your ball probe and go just behind. You see what I'm doing? Just see this very, very carefully.
Now we are going medially, posteriorly.
Now you see here, I'm going now posterior to this so-called or whatever is called the Argonazi, and you're already inside the frontal. The problem comes when there is a cell, maybe a type 3 cell. So this you should already preoperatively see whether the patient has got a posterior group of cell or an anterior group of cell. You know that there are anterior group of cells. You have type 1, type 2, type 3 cell, and of course there is no type 4 cell. That is that's a misnomer. But you have anterior group of cell is type 1, 2, 3, and 4. Of course, you have posterior group of cells. Now, if you find a posterior, what are the posterior group of cells? Number 1 is suprabullar, second is frontal bullar, and third is supraorbital. Of course, PJ's classification, supraorbital has been deleted. Now, to me, I think there's a supraorbital cell. We have seen that. So you can see 3 kinds of cells. If you find that in the preoperative scan in a sagittal view, do not do an intact bullar technique. At least in the initial part of your career, don't do an intact bullar technique, because a posterior group of cell can actually, make your life difficult if you're trying to do an intact bullar technique in a posterior group of cell. If you have an anterior group of cell, try to do an intact bullar technique. If there's a posterior group of cell, do not try to do an intact bullar technique. This is very, very important. Next question. So, what is the easiest way? Okay, I can't study the cells. I don't want to, see what kind of cell is there, but I want to open the frontal sinus. There are some people who want to open the frontal sinus. Number 1, iatrogenic frontal sinusitis is the commonest cause for frontal disease. Please understand that. If you want to open the frontal sinus, you have to open it completely. So tomorrow I'm going to show you what are the boundaries of the frontal recess. All that I'll be showing to you tomorrow. But never put in a suction and try to just push it inside into the frontal and say that you opened the frontal sinus. This is bad. Okay, but to initially open the frontal sinus, you want to feel the frontal sinus. You don't know what cell is there. I will tell you a small trick. What is the trick? Hey, give me the frontal ball probe. So this is the magic instrument. I call this the magic instrument for the frontal sinus. So you see here, you're going to use this frontal ball probe. This is a Kuhn seeker, and you're going to direct it towards this the lamina papyracea, and this is the nasofrontal beak. You hug the nasofrontal beak and the lamina papyracea. So here, you see here, the lamina papyracea is here, and this is the nasofrontal beak. Don't tilt it too much. It should be in the sagittal plane, and then gently go up. Gently go up between the. This is the nasofrontal beak. Hug the nasofrontal beak. Hug the lamina papyracea. I've seen that some people move it like this and go inside the orbit. But one thing you will never do in this technique is you will not puncture the skull base. So this is never, it will never happen. So you just hug the nasofrontal beak and stay sagittal and gently go inside the frontal sinus. This is the only way you can be sure that you are opening the frontal sinus without seeing the frontal sinus. But I strongly recommend that you see before you do this. This is what I advise. Any other question?
Techniques to detect contributions.
So I think we have come to the end of the session. I think it's already 7:30, and we will discuss a lot of techniques of dissection of various videos tomorrow. We will show you sinusitis video. We'll show you polyposis, ethmoidal polyp, antroconal polyp. That is for tomorrow. So today we had some new concepts. Think about it in your house about the Argonazi. Think about the egg model. Think about the tomato model. Think about the potato model, and come back to me tomorrow, same time at 6 o'clock. See you all. Bye bye, and have a good night. Thank you.
Thank you so very much, Dr. Janke, for this spectacular program. Attendance is such, we have exhausted our Zoom capacity.
What is your viewing capacity? What is your viewing
capacity? Was 500, and today we have applied for 1,000 immediately.
Oh. Okay.
You
so
won't believe.
Yeah.
You won't believe. Within 2 minutes of starting session,
yeah,
the capacity was exhausted, and there were 200 doctors in waiting area. I had to say sorry to many doctors. What we are doing is the recorded version we will be put on your Facebook page or some link, so that whatever they have missed out today, they recapitulate, and tomorrow we will come full flock with 1,000 capacity. Yeah,
better you have at least 1,000 to 1,500, because I'm sure that you will have definitely 1,500 viewers definitely. Because from tomorrow you're going to have more of videos, lot of good videos and tactical simple methods to open up. So there's many rhinologists want to learn the easy technique to open up a lot of sinuses, and definitely you'll have a lot of crowd, Dr. Chadha. Very, very nicely done, professionally done, Alembic, and I really thank Alembic. I thank all the viewers. In case you want to, discuss with me, you can come one-to-one now. You can unmute if there are at least some people. They can talk with me if they want, and allow some people to raise your hand if you want to talk, and you can put them on talking mode with me.
Thank you very much, sir. Thank you very much.
Some
sir.
very senior doctors are also participating, sir. Dr. from Kolkata, Dr. Shabir Haldar, sir. Many senior doctors are.
Shabir Haldar is my close friend, very close friend.
Dr.
In case you have anybody who wants to talk with me one-to-one, that is through the Zoom, please put them. I'm seeing Dr. Prakash Munkaji, my brother. He's also there from Bokaro.
Almost 100 overseas doctors are also on the board, sir.
Wow, that's very good count. Yeah.
So now doctors, delegates can unmute themselves if they want to talk to Dr. Janakiram directly.
No, but the thing is, once everybody unmutes, it should not be a confusion. So
I agree, sir.
You ask them to raise their hand and they can actually unmute. You will unmute them. You will unmute them.
Run through. Dr. H. Ravi Kishore has raised hand.
Yeah, please.
Dr. Munka has raised hand.
Yeah, Dr. Munka is you can give them.
So I am.
Sir, It's
I have
pleasure as
put,
usual to watch the basics first, and then you go build up. So we graduate, and that is beneficial to all the beginners as well as the expert. And sometimes I always keep on poking you. Don't have this instrument, what you substitute, and we always discuss that sort of thing. So the suggestion which earlier we have about, the endoscope should always visualize the instruments, and nothing should be done without visualization. So that's all. Thank you very much. And your imagination was unique for egg to tomato and potato. One can try that. Thank you very much.
Sir, you are on mute. Dr. Janki, you are on mute. Unmute yourself.
Unmute.
Charlie, unmute, sir.
I have unmuted him, sir.
Yeah. Now you are audible. Yes.
Now, actually, Dr. Mukherjee, we are seeing a lot of Zoom, and we are seeing actually the good videos done by a lot of good people. I agree. But the thing is, well, I have seen my own residents, after 1 month, when they come and start operating, they will find, oh my God, my hands are fixed. I'm not able to operate properly. So I honestly believe that the seeing a surgery doesn't translate into doing a surgery. This is very important. That's why I was thinking during the shutdown, how am I going to tell this to the audience? And Alembic has given me a very good platform where I have told them, believe me, you see here, you see, this is you will definitely have this in your house. I'm sure everybody will have this in your house. How many don't have, you please tell me. So if you don't have this, I'm sorry, you should be a pure vegetarian. But I think I take at least 6 to 10 eggs every day. So best thing is, this is actually not the broccoli egg. See, there's something about it. This is we call that natamutai. This is a natural egg, yellow in color. You see, this is not the normal egg. The normal egg is whitish in color. That is more thicker. This is more thicker. See, I didn't tell this actually. This is a very important point. So don't take the white egg. Take that, what we call the natakodi. What is that called in English? So I'm not sure. This is slightly more expensive than the white egg. And that is better for dissection. So get this, if you don't have, tomorrow go to some stores, get this, take some 4 eggs.
Boiler egg
Not the boiler egg. And another thing is, you can do the same exercise in the boiled egg and also in the tomato. Tomato, if you can do, you're simply super. Yeah.
In slang language, we called it that desi egg, desi anda.
But the foreigners will not understand. No, there are so many foreigners here. I can see a lot of foreign faces. So desi egg, the Indians.
I'll unmute now Dr. H. Ravi Kishore, who has raised hand.
Yeah.
Dr. Ravi Kishore, now you can speak. You are on unmute mode.
Yeah, Dr. Ravi Kishore, hello.
I think we'll go to Dr. Debangshu Ghosh.
Yeah, please.
Dr. Debangshu, you can speak.
Hello, sir.
Hi, Dr. Deepanshu.
Hello.
How are you?
Hello. I'm fine, sir.
Yeah, perfect.
Thank you very much, sir. Thank you very much. I'm from Calcutta, sir.
Yeah, I know.
Yeah. Thank you very much for your excellent demonstration. And the model code is very curious and very interesting to practice in my home while we're at home now. One thing I want to clarify, what I find difficulty is to find the frontal sinus. And vis-a-vis the comparison of the technique of axillary flap technique versus intact bulla. What is what and what is the advantages and the pros and cons of this? What is the beneficial for us like juniors?
See, if you are going to be a junior, a starter, the easiest way to do a frontal is the axillary flap.
Okay.
This is very clear. If you are starting with doing a frontal sinus, the first 50 cases you want to do a frontal, the easiest way is Professor P.J. Vermon's axillary flap. There is no doubt about it. Because the 70-degree view is converted into a 30-degree view or a 45-degree view. So I will show you tomorrow the axillary flap technique, how to do the axillary flap. All that I will show you tomorrow. The easiest will be the axillary flap. Second is, the easiest will be the intact bulla technique, because you're not going to injure the anterior ethmoidal artery. So you're keeping the bulla intact. You're doing an axillary flap. You're going to remove the anterior wall of the so-called Argonazi. I don't believe in that. So you take the nasofrontal, actually the ascending process of maxilla is what you take. So you take that out and you will have a direct view of the upper part of the uncinate. Remove that, you will be inside the frontal. So this is the easiest way to tackle the frontal. But if you are having a posterior group of cell, this doesn't work because the anterior wall of the posterior group of cell actually comes anteriorly. So what you have to do is, in that instance, you go to the sphenoid, take off all that cells along the skull base, identify the anterior ethmoidal artery. So something like in the thyroid, you identify the recurrent laryngeal nerve, and then you go for dissection. Same way, identify the anterior ethmoidal artery, identify the anterior fovea, then go for the frontal last. If you have a posterior group of cell, which can be seen only in a sagittal cut, or if you are able to see in the coronal cut, it's great.
Yeah. Thank you very much.
Thank you very much. Thanks, and be safe at home. Yeah. Any other person wants to talk? Any doctor wants to chat? I'm free. So I think most of you have got this book. I'm sure you've got this book that has been written by us. This has been co-authored by Professor Sethi, Omkar Deshmukh, and Arvind Gananathan. And you can read this book. We have authored it, and in fact, Olympic has given this copy free to all the doctors in India. And this gives you a beautiful cadaver demonstration here. So you can read this book if you want. Just to inform you. Yeah. So it's available on Amazon. You can order, but I don't know whether it's available now. Any other doctor? Dr. Chadda? Ms. Chadda?
Yeah, Charlie, Dr. Shailaja Kandi want to talk to sir. Shailaja.
Yeah, Dr. Shailaja, please.
Hello, sir. Good evening, sir. It was very nice meeting you, sir. I'm very happy to watch this video, but unfortunately, I couldn't understand the egg model, tomato, and potato model. Regarding what? Because I was joined very late. I'm so sorry.
No. This will be available, madam. On Mr. Chadda is going to put it on the YouTube and also on Facebook line. Mr. Chadda, you can answer. The whole video is there.
Yeah, for sure. We will share some link with you, or we will post this on Janki Sir's Facebook timeline, and the video will be made available to you by tonight only. The entire program is being recorded. We will preserve and upload this program. Right?
Dr. Shailaja.
Yes, sir.
One thing I want to tell you, Dr. Shailaja, you are young or old? Or what is your age? I mean,
I'm 34. 34, sir.
Senior person. Starting with breast? No, you're starting with breast, or you're already an experienced breast surgeon?
No, sir. I'm just a junior consultant.
Okay, you're a junior, Dr. Shailaja. The best thing I'll tell you, spend at least 1 hour every day on the egg model.
Okay,
this
sir,
is
sure.
like a very important advice I'm giving to all of you. Don't make your hands rigid, because this is the time. Because hereafter, I don't know when we are going to start elective surgeries. We don't know.
Yes, sir.
So this is the time when you remain with your hands fixed. Then that's it. That's the end of your surgical career. So the best way is to dissect the egg model. That's why I brought this egg model and demonstrated. So the whole world, I request that you keep your hands always enough of every day, at least 2 Zoom meetings you see. After that, practice on your egg model. You can do head and neck dissection also in this. You can do whatever. You keep your microscope. You have to have a lens, just a lens, the 2x lens, and keep doing it. So you see the video and you will know what I talked about.
Okay, sir. Thank you, sir.
Charlie,
Sure. I will definitely.
Dr. Sudipta Tarun Sen.
Hi, Dr. Sudipta. He's from Calcutta, right?
Sudipta Tarun Sen. Charlie, unmute him. Hello.
Hi, Dr. Sudipta.
One of yours, I'm very much impressed whenever I see you operating or even see you operating on video, sir. So I have a question, sir. When I'm operating on the sphenoid area, sir, and it's very edematous, I find it at times I'm very scared to go ahead because the landmarks become very confusing. So what is your technique?
Okay, the best, easiest technique I will tell you. This is a very common finding which many people say. Not only you, many people. Especially when there is a multiple polyposis or there is a revision case, you are not able to find the sphenoids. Correct? Exactly. So the best way, the best and easiest way, they get in the flexible wall probe. or straight ball probe. You have to get this instrument after the lockdown. Ma, sphenoid ball probe. And the yellow ball probe. I will show you the instrument. Please buy this instrument. This is available with all the Indian surgical companies. Wait. Okay, this is the instrument. You see here. This is again a magic instrument for me for the sphenoid sinus. You see, this instrument has got. Can you see here the tip here? Hello, Dr. Sudipta.
Yes, I can hear. I can see it, sir.
Can you see the ball tip? A ball tip, and then you see it's a very flexible instrument. It doesn't. It's not rigid. So what you can do is this is the best instrument for the sphenoid sinus. So you make it straight, and then you go, see here, you take the landmarks, the following landmarks. You created an intermediate window, that's a superior meatal window. You hug the septum, and then stay parallel to the basal lamella. So this is the basal lamella here, the bulla, the basal lamella. This is the superior turbinate. Between the superior turbinate and the septum, you just have to use a blunt ball probe, a straight ball probe, and just slightly, you hold only with the two hands. Don't hold very tight. Gently, you just keep palpating like this, above. It will move inside. It will just drop like a baby inside. Then you know that's a sphenoidos. So this will not damage the carotid. This will not damage anything. You keep this like that itself. You keep this probe inside like that itself. Then you use a Blackersley and gently separate it, and you can widen that os. That is the easiest way to open the sphenoidos.
Okay, so thank you very much, sir.
Thank you. So I think Dr. Chadha, Mr. Chadha, I think we'll call it a day. I think we have done a lot of work. It's 8 o'clock. So thank you very much.
Yes. Thank you.
Thank you.
So we'll keep this excitement on, and we'll meet tomorrow on Zoom, sir.
Absolutely.
Thank you very much.
Absolutely.
Good night.
Thank you.